Mr. Jayraman is the Senior Manager Fresenius from Tamil Nadu. So far we have heard from nephrologists of how to, what are the advantages and disadvantages of hemodiafiltration. Now we'll hear from the technical aspects of online hemodiafiltration. He is also one of the Fresenius is also one of the sponsors for this session today. Over to Mr. Jayraman.
Before I go into this topic, I would like to thank Professor Lobo. Yes, I would like to use the word professor because he made my life easy. And I also like to thank NIMS Hyderabad for really taking this opportunity to bring Fresenius and me to be here this day. Here we go with the presentation. So the topic will be discussed, the flow of the topic will be a little bit on the dialysis fluid, how to handle if you have an Indian RO system. Not necessarily it is affordable by your end to go for a imported RO system. And what is UPDF? My previous speaker did speak about UPDF, but I would like to give a narrow down into a nutshell and how to achieve it. A little bit on the technical sides, the internal parts and other things and the overview of the mission. The hydraulics, though Professor Lobo had walked through a complete, which might be a little bit complicated by seeing on the screen, but he would have delivered better than me. Then a little bit on the convent study, the previous speaker did touch. I am going to go directly into that, what dialyzer they used and what should be really used. Finally, the references. So how to achieve this purity of the dialysis fluid? I, as a therapist, I had been from 1987, we were using the DM plants, which we found it very difficult, and I'm really thankful to Professor Mani, who is Padma Bhushan. I am the first student of him, who went abroad, more than 20 years abroad. And to achieve those days, it was really very, very, very difficult, cumbersome process. But now with the latest pore size of 0.0001 micron meter of the RO membranes, which is also polysulfonopolyamide, we are able to achieve these standards. And I'm not going to walk through every single thing in this slide. How to achieve it? A regular backwash, which is usually not done from the hospital end, which is always handed over to the maintenance engineers, and it is really a difficult task to achieve the water quality. Not that you should have an imported RO system and I'll achieve the UPDF, nothing like that. If you come to Chennai and part of Tamil Nadu, I do have the online hemodiafiltration missions with the Indian RO systems with a pore size of 0.001. ISO standards do state about how to achieve it, and Fresenius will help you, guide you to achieve that. And if you see this slide talking about purity of the dialysis fluid, I would say purity of the water should be taken care of. Where is the crux of the problem? We try to store the water into the tank, and then we try to pull it through the narrow pipelines, dialysis unit, and then we see all this culprit of the bacteria that is going to go through the UV rays, and the cell wall of the bacteria is going to be broken down by the UV light. And what releases is LPS, and that is going to go, especially on a Sunday morning. They do the disinfection. Monday morning, I used to get a lot of, because inside the ROs in the tank, you have the grandfather, the grandmother, then the grandchildren, the father and the mother, all swimming and happily living. Morning, they go and disinfect. Monday morning, I get the headache because all this happens. So how to achieve it? You need to see that the RO system, which has the sediment filters, has to be backwash frequently every day, at least half an hour rinse and half an hour backwash, followed by the regeneration of the softeners. Normally, when I walk through almost 3,900 hospitals in India, I have traveled, what I see is the regeneration, how many times they are doing, if I ask, not few professors sitting here, maybe I am telling wherever I have seen, they say I do it once a week, twice a week, nothing like that. It all depends on the timers. If you have a timer, the RO system who has laid it in the hospital will give you a timer, say this many number of liters passes through softener, automatically goes to regeneration. The healthcare provider needs to only take care of the salt level. Most of the time when I walk into the dialysis unit, I see the salt level slightly lower and the water level is also less. It should be water level above the salt level so that the air doesn't go in. And the other thing is the salt quality should be a salt pellet, not the rock salt, which will have not the exact sodium content, which will be impure, and that will see that the efficacy of the resins not doing the job. And finally, it goes on to the RO membrane, which is blocked, and the ultra pure water is not achieved. Once you get the UPDF, I think the RRF is maintained. Then you see no inflammation because of the UPDF. You can also see the erythropoietin response by seeing the hemoglobin maintained and the erythropoietin dosage is reduced. You can also see because of the ultra-pure dialysis fluid, you will see dialysis-related amyloidosis. The risk is definitely minimized. When they did a comparison with the standard versus the ultra-pure dialysis fluid, by the way, I would like to say even for hemodialysis, you need to have the ultra-pure dialysis. So if you have that, definitely you can see the risk of cardiovascular events minimized. So how can you achieve it? One, you need to see that every day it is a backwash and a rinse, both the sand filter and the carbon filter. The regeneration depending on the number of liters. Then those tiny filters in between every particulate filter, you need to see that the columns have to be replaced by checking the pressures. Many of the units, I'm not mentioning the units, they try to reuse that 5 micron filter or 10 micron depending on different companies give the filters. So I would say if the pressures are high, you need to replace it, not reuse it. Finally, the RO membrane quality outside. Where do you need to check the calcium levels? The hardness should be exactly after the softener. That means after the softener and carbon filter, you should see the chlorine and chloramines. Indian RO systems is not designed properly to have a sample port after the softener and after the carbon filter. Maybe think to a minute to ponder and rectify that. Once that is there, I think you have a good dialysis machine, which is online HDF machine, having 2 endotoxin retention capacity filter, which is at 0.2 microns. You do have in the RO system, which is not online, you also have after the UV lamp, which is an endotoxin retention capacity filter, which is 0.2 microns. So after the dialysate is manufactured by the machine, it has to pass through the endotoxin capacity filters or the retention filters, and what comes out is an ultra pure dialysis fluid. Over to the technical insights. There are a lot of challenges in India. Even if it is an Indian RO system or an imported RO system, one needs to really do a hardness test and a chloramine test, because the machine is going to automatically manufacture the replacement or the substitution rate manufactured by the machine and delivered to the as a substitution fluid into the systemic circulation. So one needs to really have a calcium report as well as chloramine every 4th hourly if you are doing online hemodiaphy. Ideally, even for HD, you have to do. And you need to see that the water pressures are exactly maintained. As Professor Loba had already mentioned, you need to have 1.3, it's actually 1.5 bar, even 0.1001 deviation, the machine will give you a water pressure alarm, then only the other hemodialysis machine, because there are 2 pumps parallelly running. One is the dialysate pump, one is the substitution pump. So you can't use your liquid bicarbonate because they are either it is by a bicarb mixer or whatever. You need to have a dry bicarbonate because the dry bicarbonate comes in 650 grams and 900 grams. You ideally have to use only 900 because part of it goes into the dialysate compartment for 500 ml per minute or 800 ml, and the remaining one is used for your substitution fluid or a replacement fluid. All dialyzers and blood lines, even for HD, ideally it is 2 oblique in a circle. That means it's only single use, not only for your hemodiafiltration. So what all you can do with this online hemodiafiltration machine? You can do a SLED, you can do SLED-F, you can do online hemodiafiltration pre or post dilution, you can also do HF, and you can also do normal hemodialysis. It's basically a touch screen. To me, it's just a gimmicks. it doesn't enhance anything or help in terms of the adequacy of dialysis or a clearance. So you have a work chronological order. That means a healthcare provider needs to just follow the lower menu, where you need to go for preparation. You need to you no need to use any saline. You don't require an IV set. This is automatically manufactured online with your acid bicarb. In between you have the RO water. You have a mixing of 1 part of acid, 32.775 liters of RO water plus 1.225 is your bicarbonate. All will mix, it's 1 plus 34. So I already mentioned, one you can do is, if you want HDF, you can come back to HD, or you want from HD to go to HDF. In your CRRT machine, you only have to start with HDF, cut off your substitution rate, it becomes HD. Or you cut off your dialysate flow, it becomes HF. In this, you can play with it. I have been doing for the last almost 18 years with this machine. From 2004, I was abroad. I have been playing with this machine, even in ICU setup. For your information, it is not the imported RO system, it is just an
Sponsors.
RO system. Only thing, one dedicated health care provider inside the RO system, maintaining every 4th hourly and correcting the things, and also disinfecting the pipelines with the right disinfection and the right disinfection time. What do I mean? You need to do I'm not telling every week, I do every week. Right from 87, we were doing with formaldehyde. Now we have a parasitic acid. You no need to wait for 24 hours. It's just 1.5 hours, you finish your disinfection. And I will tell you that whatever you do with the right disinfection time, I think the ultra pure water is made available at the membrane outlet. But when you store it, what I do is, I recommend when they do the 5000 ATS, keep only 250 liters. This no books gives this. I am a more practical guy. I leave only 250 liters. Even there is a breathing difficulty, 2 patients, you require only 30 liters per hour. So you can still manage with that little bit of liters that is in the tank. And early morning, especially Monday morning, we drain it off, because Saturday to Monday is Saturday evening to Monday morning, you don't have dialysis patients. So we remove it and then refill it. So we have lot of advanced features with this machine. Probably next 20 minutes I'll walk through. Blood temperature monitoring. What does it help, and in what does the patient benefit? You also have auto suppress, both manual and auto. Then we have the venous access monitoring. What is this beneficial? In 4008 years or your normal hemodialysis machine, what is the level? And with this machine, what is the safety level? Lot of softwares are coming. I am just minimizing, not going too not too technical. You just have to guide the blood lines through your flap. I'm not able to point it. That red one, you just have to open the flap and guide through, and the venous one. So the dialysate temperature, even ideally speaking with your hemodialysis patients, it should never go more than 35.5 to 36. I have usually kept around 36, the max. The reason is, there is a back diffusion of the temperature from the dialysate to the blood, even in hemodialysis, and because of that temperature going into the body of the patient, systemic circulation, it goes and hits the hypothalamus of the brain, it senses, and the core temperature goes up. When the core temperature goes up, it directly hits the vessel, and the vasodilatation happens, and the blood pressure comes down. But with this system, I think you keep a 35.5 to 36, the body temperature is automatically adjusted by this. But healthcare provider cannot go and meddle with the temperature, because it is automatic. Only if he goes and switches off manually, then he can. Usually I don't tell them to do that. It helps in an access recirculation or a CPR, cardiopulmonary recirculation. Mostly I see with catheters, yes, definitely we know access. I'm talking about the fistula. Probably it is between 4 to 6, my experience I have seen, more of a CPR. Auto suppress. The basic thumb rule for an online hemodiafiltration, you need to have a very good vascular access, because in India, overseas, we always monitor the arterial monitoring. India, we usually use a post pump and we don't monitor the artery. But with this 5008 or whatever online missions, we have purposely introduced the arterial monitoring, which is chamber free. That means directly the blood goes through a protector type, which is an arterial pressure dome, and it will measure the arterial pressure. In a way, that will be the accurate one for the effective blood flow rate of that ex-patient. So what I'm trying to tell you is, this is automatically calculated based on the effective blood flow rate. That is the reason most of the time the substitution pump will stop, and twice, probably 3 times it will stop the pump, and third time it will become HD. You can see, you would have programmed, not you means you, the healthcare provider would have programmed HDF, but it will automatically change to HD because the auto supplies will be calculating based on the effective blood flow rate. It usually calculates the first 15 minutes, it will maximize the TMP, and it will achieve the based on the effective blood flow rate. Say for 300, it might start approximately at 62.5 mils per minute. This is my experience. And how does it calculate? When the blood enters the dialyzer, you have a frequency and amplitude, and the blood leaves the dialyzer, you also have a frequency and amplitude. And every second or every minute, you have 1,000 dynamic signal passing through the dialyzer from the arterial to the venous. And when the blood leaves the dialyzer, say after 1 hour, there is some resistance felt in the fibers. Automatically, you will be seeing in the frequency and amplitude, which is in the venous end. That from there, you will have a biofeedback directly to the substitution pump, which is below the blood pump. And that will definitely reduce the substitution rate. Say it has started, say around 80, it will come down. The reason is, it has already felt the resistance, so the substitution rate will come down based on the program that is given inside the machine. I have seen approximately around 5 to 10 mils, it will get reduced. So it is automatically prepared and automatically infused to the patient. The previous speaker already talked about pre-dilution. When do you use a pre-dilution? When there is a patient who is bleeding, yes, no anticoagulation given, so the blood is diluted with the substitution fluid, which might be starting at 25 ml per minute. It can go up to 600 ml per minute. I have seen with my experience, we in Singapore and abroad, many countries, where it goes even up to 480. I have seen even 40 liters, as Professor Lobo did mention. So when such number of liters go in, you no need to program how many liters to be removed, whatever is shown on the display. It is automatically removed, whatever the machine is going to be generating the fluid, pushing into the body, and simultaneously removing it out. The only thing is, pre-dilution, you will only have the clearance reduced, but to me, when you are doing a pre-dilution, you automatically have to increase the time to compensate the clearance. Post-dilution, I think most of the people sitting here would have seen only post-dilution, but then which is with heparin. The clearance I have seen is amazing. With the last 5 years with one of the units, I have seen even the wound healing in some patient. Lot of medications were given to that patient, but then I found, because of this hemodiafiltration, this is not to touch or win your heart, this is from in the name of God, I'm telling, the patient's wound has got healed. I don't know, probably some of the things have been removed from which is creating the wound to heal. There is one mechanism inside the thing where normally in a hemodialysis machine, the venous pressure drops by 30 millimeters of mercury, whereas this machine drops by 15 millimeters. It will immediately stop the pump and it will create an alarm. And then the healthcare provider needs to go and correct it. Probably there was a protector wet, or a protector came out, or the needle slipped out. VANAC, probably I was the one, Jaya Engineering College, the owner, peace be upon her, she passed away on July 1st. We were the one who first brought this, but then it is very expensive. You need the biopatch where it has to be introduced, and then if it is wet, below the needle, it will immediately detect, and you will see that it sends an ultrasonic wave sound to it's not connected. The one you see on the other side, it's not connected. It's only the wave that will go there and it will stop the pump. More for a pediatric is better. Blood pressure monitoring is a normal one, non-invasive. KT over V, I know most of the professors and nephrologists will not really look into if you're going for online hemodiafiltration, but I would also see it is free of cost. You only have to program certain parameters like the dry weight, pre-weight, and your hematocrit of that patient, and then with 25 minutes of measure gone, it measures and gives you a forecast. That means, what I'm trying to say, even with your hemodialysis system, you can know whether the patient is a malnutrition, Why malnutrition? Because of inflammation. And second reason, whether it's an access recirculation. Third, you can also know the plasma sodium. Mostly the plasma sodium should be approximately what you have prescribed when the professors have given, but healthcare providers will always see it is somewhere around 140 to 145. The culprit is if they are using not with the 5000 ATS, with probably the hemodialysis machine, it is normally the the RO system is not properly maintained, and you see the sodium creeping in, and then it always happens in the mid shift or probably in the later part of the day. And you have alarms monitoring, so you need not worry. The moment the machine gives an alarm, the blood pump stops, the line gets clamped, the venous line occlusion clamp, and then you will see a visual and an audible alarm. And you also have a help button. If the person is a student, can just know what is the alarm reasons. And you have a trouble-free alarm, the air-free, which is because you don't have chambers, arterial chamber, it's just a protector type. You have continuous, probably every 5 balancing cycles, cyclic pressure holding test to check whether there is a leak of the hydraulics. And you also have below the doors, you have a groove which can hold 30 ml. There can be sometimes when they are priming, it would have creeped drop by drop, and that is the reason it will give you a hydraulics leak, or just below the probably where they keep the disinfectant. There also you can see the leak, and then it will trigger the cyclic pressure holding test. Sometimes you can see the failure. The leakage sensors is here, what I was telling you previously also. The leakage sensor below the groove and below the filters. If it is for 5008, it is on the just next to your couplings or the dialysate in and dialysate out. But if it is a 5000 ATS, it is at the rare end where the disinfection is there. The other beauty part is if the filters or the dialyzer is connected, it is on the perpendicular type or a cone type. But this is a one, so you don't have a kinking, so you have an adequate blood flow, you have an effective blood flow rate exact, and you will have the substitution rate exactly delivered and removed. Normally in a hemodialysis mission, the healthcare providers, when there is a blood pressure drop, he goes and switches off your first action. Second, he will give a saline, and third, he will try to reduce the blood flow. Fourth, he will check the blood pressure. All this can be done by just one touch of this emergency, and then all things happen. But it doesn't end there. Once the action is over, 50 ml per minute it has come down, so it will not allow the operator to go away. It will tell the person to increase the blood flow because it has a direct relationship to the substitution rate. So it will tell you to increase the blood flow to the original blood flow rate, so that the substitution rate, again it will go for a calculation, and then it will start to go into the treatment mode. Sir had already mentioned about the heat disinfection process. Overseas, it is mandatory to do start of the day, or if the machine is lying idle for more than 24 hours, and then in between treatment, you need to do a heat disinfection cycle, because there is a calcification or calcium deposit, so you need to descale or decalcify it. So you need to use the right disinfectant into the dry disinfection mode. So at heat disinfection, it is at 84 degrees Celsius, and you have a citric which is 21 grams or a 21%, it will decalcify or descale. The remaining two, which is lactic acid and malic acid. Malic is one which you see in the apple, you cut and leave it. After 3 to 5 minutes, it will become golden yellow color. So when I walk into the dialysis unit, whether they are using the right disinfectant, I will find it from the dialysate line, which is golden yellow color. Then I know they don't have the lactic acid or the right disinfectant being used. What does the lactic do? Lactic will also act as a disinfectant, and it lubricates, and it also maintains the pH. Battery backup is there for the engineers, which is lot of companies come with 30 minutes, 25 minutes. I would say 15 minutes is ideal. That means 10 minutes you can run the pump. That means dialysis doesn't take place. It's just only the blood pump which is rotating to keep the blood moving in freely, not clotting. And that 5 minutes buffer is to return the blood. You have a user-friendly inlet. That means you have a arrow in, arrow out. So in a normal dialysis machine, you will only go with the color coding. Here you have that in and out. And then you have the dry bicarbonate. You just have to lift it, remove the seal, fit it, shut it, and you need not forget it, though the terminology Fresenius gives. I would say never forget it. You need to be by the side, monitor the conductivity, because based on the conductivity only, whatever is going into the patient will be I know it will give you alarm if it goes low. You cannot adjust like the normal other dialysis machine where they'll go and raise it even to 14.6, 14.9. No, in this you can't. You have only probably 0.2, you can go up, 0.2, you can come down. You have a data management, but you need to use your patient card to retrieve the data and then go to your patient management system where it will be automatically captured. You no need to keep on scribbling, writing, and wasting at least 28 minutes. That's my calculation time for one patient for one treatment. Easy to service, yes. You need to only pull the hydraulics. This more for the engineers, as Sir said, Professor Lober rightly remarked, you need to have a service card. Without the service card, you can't do. Like I am a trainer, country trainer for most of the missions, and I have my own card, which is user card. I also have the service card now, recently got it. So when they remove it, they can go into which valve, where, which function as it has malfunction. They can know it, but then the correction is from their end. They have to do it manually only. You don't require a saline, you don't require a pail because it's fully sterile. You only have to connect it, close the door, have a cup of coffee, the machine is ready. Even your normal dialysis machine, your 4008, yes, if it is a new tube, new dialyzer, you can do an automatic priming. Autoflow is normally what we do as a healthcare provider. We need to go manually into the dialysis menu, select 500 or 800, whereas autoflow, you automatically, it can go into whatever is the blood flow rate times your factor, which can be 1, 1.2, 1.5. Usually the studies show that after 2 to 2.5 hours, the urea clearance becomes plateau. But when you're talking about online hemodiafiltration, we not only look into urea, we are looking into more of the convective dose, which can be leptin, which is an Unger syndrome, and you can also look into beta-2 microglobulin. So when you are trying to reduce the dialysate flow a little bit, save that and you are utilizing it for your substitution fluid, and thereby it is cost effective. You also have economical flow. Economical flow is what? During the normal dialysis machine, when they are doing a priming, it is at 500. Nobody tries to bring it to 300. My older days, as Sir was telling, Cobe, I have used Ultraflex, I have Ultratouch, I have used Althin 1000, many older machines. We don't have the dialysate flow starting less than 300. So we used to manually go there and program it, but here in this machine, you have automatic 100. When the blood touches the optical detector, automatically goes to a default value or a prefixed value, which is at 500. But during this economical mode, do not send the electrolytes, do not send the dialysate sample for electrolytes, because you can see below the bicarbonate value 25. Okay, the bicarb, prescribed bicarb 32, below that it's 25. So during economical mode, if the dialysate sample is sent for electrolyte analysis for bicarbonate, it will not be more than 25. I think we are coming almost. Three more slides. So the Sir was talking about water coming in, heater is there, thermostat like our brain, thermistor, and you have a heat exchanger assembly before the heater. So when the spent fluid, it has already heated and gone and it is coming out of the dialyzer, it's already at a X temperature, say 36.5. So the incoming water is less. This will transfer the heat in the heat exchanger assembly to the other side. So the incoming water is already heated. When it goes and touches the heater, the thermostat is like our hypothalamus. It will stop and say, array, you no need to heat. Thereby, what I am trying to mean is the water that is not going to be heated, that means the consumption of the current is lesser when compared to any other brand machines. So after that is heated, heat transfer, it goes before the acid. The acid is one part, probably 34 parts of RO water if it's your normal hemodialysis machine. But if you're using a dry bicarbonate, it is 32.775 RO water, and then the bicarbonate will be 1.225. All this is mixed. It goes into a degassing pump. Of course, it will deaerate, and then it goes through the 2 endotoxin retention capacity filter. The first one, it will pass through, and what comes out through the pores will again go through the second endotoxin filter, and what comes through the fibers will definitely go to your dialysate compartment. That means it has already double filtered going to your dialysate compartment of the patient, ex-patient. what comes out of the second endotoxin retention capacity filter pore size is 0.2. After it comes out of the second endotoxin pore size, it is going into this as a substitution fluid or a replacement fluid into pre-dilution or a post-dilution. Thereby, in ISO document part 5, it states that it is already sterile and non-pyrogenic. Then why not I use it for automatic priming? And we do it. That's the reason my couple of slides before I said you don't require an IV set and a normal saline. So the consumption of the consumption of, if it is hemodialysis, it is somewhere around 0.87 ml, the acid, and the bicarbonate will be somewhere around 1049 mils. Your RO water will be around 27,000 liters. Okay, so when all 27 liters, when you see all are mixed, approximately 30 liters. That's the reason I said we need 30 liters per hour. So 3 patients are there also. With 250 liters you should run. And when you have a 1000 liters per hour RO membrane output, it should easily fill into the tank in the next half an hour. 500 liters will touch. So after it has mixed, it goes through the balancing chamber, which is 30 ml, 30 ml. And you see a small tiny pump, which is UF. You can see 1 ml. The stroke is 1 ml. So if you set, say, 600 ml per hour, that means 10 ml is the stroke. So it will give you a pull of 10 ml plus 500 ml per minute is the dialysate. So 500 will go in and 510 will come out. But then the capacity of the balancing chamber is only 30 ml. That 10 ml will not enter back into your patient's balancing chamber, that mission chamber. It will go separately, but at one point of time before going to the drain, 500 will meet with this 10 and go as 510. So to repeat it, balancing chamber is only to pull the fluid, pull the fresh fluid, go to the dialyzer, and what spent fluid comes will come on the other side of the balancing, the diaphragm, and then it will go out. The extra fluid from the patient body goes directly. It will not enter the balancing chamber. Convince study, the previous speaker did talk about. It talks about somewhere more than 23 liters. So I usually tell my professors and my nephrologists, Indian patients can't go more than 300. The reason is we don't have a needle size in India more than 16 gauge. We don't have 15, we don't have 14. So if you want to go further higher, patients fistula is also good, but then we don't have a needle size. So probably we hit between 18 to 20 liters. That's the substitution fluid. Then I add 4 liters of is the ultrafiltration of the patient. That is also coming as a convective dose. So when it comes out, we calculate it and we say that we have somewhere touched the Catalonian Eschol study, which is somewhere 21 liters. So now the Convince study has come. This is almost my last slide. 1,360 patients they have compared, and they have not used the dialyzer that is existing in India. I have to honestly tell. They have used an FX coral dialyzer, which has a hydrogel inside. That is definitely enhancing the clearance, because one of the speaker did mention of the polarization probably after 2 hours or whatever, and that is definitely hindering the normal middle molecules or a better higher molecule clearance. So what I'm trying to say is, even if you don't have that, we have a dialyzer which is having a higher diameter and a larger the wall thickness is also increased. Whereby it can definitely withstand the pressure or hydrostatic pressure, because you try to use a negative pressure across the pore size of 3.3 nanometers, and definitely it will definitely pull whatever you want, maybe 23 liters or even 40 liters it can withstand, which is FX Cordax hemodiafiltrated to 210 diameter with a 40 micron meter of a wall thickness. And finally this study has concluded, Peter J. Salute him, he has come with a study telling that the mortality rate is definitely reduced. But for that, you need to have a very, very good vascular access, a minimum of 350. Above 300 was the study. So if at all you want to have a hemodiafiltration, the first condition will be you need to have a good RO system and probably maintain it, let it be Indian RO system. If you can't achieve the ISO standards, I would say put a portable RO system if it is for online HDF. And then they will also talk about the cost, but cost I can come and tell you how to take back that. I can definitely tell you. Maybe the initial investment is there. Already existing RO system is again going to go through the second one, which will enable you to achieve the ISO standards of CFU less than 0.1 and an endotoxin of 0.03 per ml. But in India, with that I will leave. In India, the difficult part is, I think Professor Robo will also agree, we in Tamil Nadu also, we find it difficult, except Apollo and many other few labs, which is not NABL. They try to give a value of less than 1 because they don't have a kit or they don't have a testing facility for an endotoxin testing. Usually it should be TGEA, tryptose glucose extract agar. Normally I get a report within 2 days, which is soy agar. I usually don't initiate it. Then I go and talk to the microbiologist. I want this medium. I want 7 days the time you give me. And most of the labs now, they have brought that and they are giving me the report. Some labs give me no growth, so I don't accept. I want per ml, so that I want to improve. Hope I justified in giving you. I know I couldn't equal Professor Loba. I have done my job, I think. Any questions? Open to the audience.
Thank you, Jayraman.
Thank you.
So thank you for that excellent talk on technical aspects coupled with the clinical picture. So do you have any key messages for our dialysis technicians to ensure the maintenance and safety of an HDF machine in the unit?
Only thing I would say is, if they can disinfect the machine, of course it is automatic, nobody can stop or bypass it. Even if they stop and put it to rinse, the machine will not allow to go in the conductivity test, it will definitely fail. Second, I would say they need to test the RO system, though they might hand over to maintenance. The calcium, chlorine and chloramine is mandatory because we don't use a 5-liter bag, which is already sterile and within the range. This one needs to practice it because they have not cultivated this habit. In HD, we don't do that. We only just fill the water and we see the conductivity done. But here they have to do these two. One, test the RO system. Second, disinfect it. If they do these two, I think they have no problems with the machine running 4 hours now. They can even run continuously 24 hours. My experience in ICU setup I have done recently, 11 hours I have done HF. 11 hours I have done HF. Of course, it was Indian RO system, then I put a portable one. And I didn't go into the auto mode. I went into manual, like you do the CRRT calculation 25 ml per minute. You can do that also. Why I didn't want to do automated mode is because automated will try to increase sometimes and my filter will go. I wanted gentle one and it was an ICU setup and I managed to do that. This is my experience.
Any more questions from the house? So, if no more questions, we'll conclude the session.
Thank you.
Thank you, Mr. Jayraman.
Thank you. I think it was a wonderful session, and I really thank all the speakers who have come all the way from Maharashtra, and then we had one speaker from Tamil Nadu, and all the experts panel of doctors who have had a great talk. And I think all of you have learned something out of the other, and you realize the importance of machines now. Don't leave everything to a technician.